Hello, good evening everyone. Myself Vandana Kushwaha, working as a junior cardiac physiotherapist grade 2. Today, as a part of CPE training, I will discuss about the bronchial hygiene techniques. In bronchial hygiene therapy, it important in both the ICU patient, means in long stay ICU patient, or in some respiratory condition, in which the bronchial hygiene therapies involves the use of non-invasive airway clearance techniques and invasive. In non-invasive therapy, it helps to mobilize and removes the secretions and improve the gas exchange. It used to mobilize secretion, facilitate the mucociliary clearance. It goals is reduce the airway obstruction, improve mucociliary distance, ventilation, and optimize the gas exchange. Is example like in condition cystic fibrosis and bronchiectasis. Indication: cystic fibrosis, bronchiectasis, atelectasis, respiratory muscle weakness, neurological or metastatic any disease, mechanical ventilation, neonatal respiratory distress syndrome, and asthmatic patient. In all the condition, patient respiratory muscles and respiratory bronchioles are involved. So both the techniques are important. Which in these techniques we are covering about the different techniques. First is cuffing, postal drainage, percussion, vibration or shaking, ACBT, autogenic drainage, high frequency chest voice oscillation, PEP, and suction. These are different techniques. We are first cuffing. It is the forced expiration against the closed glottis. It causes the rise in intrathoracic pressure. Is coughing and huffing both are the forced expiratory maneuver which are producing the rapid flow air combined with narrowing of airway, dislodge the secretion and move it toward the pharynx and easy to facilitate. Second is the postal drainage. It's a passive technique in which the patient is placed in different position. They allow the bronchopulmonary tree to drain with the against the gravity. It also used with other techniques, modify position, and when ideal one is contraindicated. When patient is under contraindicated condition, then other techniques are used and other position are also used. In which determine the lobe treated, patient put in different position according to involvement. If PD is used, position taking the 5 to 10 minutes minimum. Don't treat each affected segment during each treatment, otherwise the patient muscles become fatigue. Patient should be encouraged to take a deep breath, cough after each treatment. Patient sit upright or lean forward to optimize the effort. Different patient position we will cover. Indication of postural drainage. Pulmonary disease associated with the increased production of viscosity of mucus. Example condition like chronic bronchitis and chronic flare. Prolonged bed rest, restricted deep breathing and coughing post-operatively. Patient on ventilator, pneumonia, atelectasis, COPD and patient with artificial airway. Contraindication in severe hemoptysis, in which the patient is hemoptysis, patient have chances of thrombus and hemorrhages also, so it will contraindicate. Severe pulmonary edema, CHD means congenital heart disease, large pleural effusion, if untreated they are contraindicated. Pulmonary embolism, pneumothorax, in pulmonary embolism also contraindicated due to the chances of hemorrhage also. Cardiac arrhythmia, severe hypertension or hypotension, recent MI means myocardial infection and unstable angina. Third is percussion, is aimed to loosening and retain the secretion from the airway. They may be removed by the suctioning or expectoration. Is clapping, in clapping different technique how to use in perform during the inspiratory and expiratory phases, in which also the PD position will also cover. Equipment, percussion given by other part, so caregivers also mechanically stimulate the percussion available of the variable frequency and intensity. In preparation, patient put P in PT position, cover the part with the towel or hospital gown, level the bed, so proper body mechanics is used for treatment. In which the cup the hand, wrist, arm and shoulder relax, put in thin position, hollow sound, steady rhythm, rate between the 100 to 40 per minute, force from each hand should be equal. In infant uses the three fingers and middle tendon. Not over bony prominence and breast tissue will cover percussion. Advantage and disadvantage: enhance the secretion clearance and shorter treatment. Rhythmic soothing, relaxation and sedation. Not well treated by patient post-operatively without pain control, osteoporosis or coagulopathy, frank hemoptysis. In vigorous and rapid malod breathing holding bronchospasm in patient with the hyperactive airways. Fourth is vibration and shaking. Vibration involves the gentle high frequency force and shaking more vigorous compared to vibration. M is moving the secretion from the lung periphery to larger airways, suction and expirate. With PD position perform only during expiratory force. In which equipment we continue manual caregivers, and these are also passive techniques in which mechanical vibrator, infant padded electric toothbrush. Preparation in patient also put in position different PD position. We also use towel gown and body position of caregivers. In treatment procedure, frequency manual vibration between the 12 to 20 Hz and shaking in 2 Hz. Advantage and disadvantage: enhance the mobilization of secretion, better tolerated than percussion, allow the access pattern and depth and respiration, cannot apply himself. Fifth is ACBT, means active cycle of breathing techniques, in which include the three phases. PD position may be used, in which includes the breathing control first, second is thoracic expansion and third is forced expiratory techniques. In breathing control, we are including the diaphragmatic breathing at normal tidal volume. This phase should last till the patient relax and prepare for the next phase. It usually controls the 5 to 10 seconds. Second is thoracic expansion, in which emphasis the during the phase inspiration and in which the deep breath to inspiratory reserve volume and expiration is passive and relaxed. Patient or caregivers place hand over the treated area to encourage the chest wall movement or chest wall oscillation. Percussion, vibration or shaking may be performed with the thoracic expansion as a part of exhales. For surgical patients, those with lung collapse or breath hold at the end of inspiration and encourage the collateral ventilation to assist with the re-expansion of the lungs. In which the discuss about this picture, bronchioles and alveolar spores, how to expand. In third is forced expiratory techniques, consists of huffing. In effective huffing, mouth open, O stroke to keep glottis open. Forced expiration from mid to low lung volume moves peripheral secretion, from the high to mid lung volumes moves proximal secretions. Muscle of the chest wall and abdomen also contract and sound is like a sigh but force. Rate of expiration flow varies with the individual, the disease and the degree of airway obstruction. In crackle heart, if excess secretion are present. Breathing control after 1 or 2 huffs to prevent any increase in airflow obstruction. If secretion is tenseous, then 2 cycles of thoracic expansion used to loosen the secretion. In bronchospasm or unstable airway, breathing control is as long as 10 to 20 seconds. And after surgery techniques to support the incision with the hand during forced expiratory technique to achieve the sufficient expiratory force. In ACBT cycle, we are shown in the pictures. In first we will breathing control, thoracic expansion, then first also breathing control, huff and then breathing control. If secretion are tenseous, we will also discuss, then do 2 times breathing control as used. In breathing control, thoracic expansion, breathing control, then huff, then second time huff and then breathing control. And third is in thoracic expansion, breathing control, thoracic expansion, breathing control, then also thoracic expansion, breathing control, huff, then breathing control and huff by patient on. When huff from the medium size inspiration through complete expiration, non-reproductive and dry sound of 2 cycles in a row, the treatment may be concluded. Its advantage and disadvantage: allow to participate actively and may be introduced at the 3 to 4 years of age and become the independent at the 8 to 10 years of age. A decrease in oxygen saturation caused by the percussion may be avoided by the using of SAB techniques. Assistance is required in young children and ill patient in whom percussion is shaking during the thoracic expansion phase. 6 is autogenic drainage. It uses the expiratory airflow to mobilize the bronchial secretions, self-drainage method and sitting position. In we are also included 3 phases. First is unsticky phase, in which loosen the secretion in peripheral airway. The collecting phase moves the secretion to central airways, and the evacuating phase it result in the removal of the secretion. First requires the mucal patients and concentration to learn, so not used for young children. In equipment, no any equipment must be used. It proprioceptive facilitate and auditory perception of mucus moving. Preparation, it site upright chair with black patient. Surrounding should be divided. Distraction allowing patient to concentrate the breathing technique. Upper airway should be clear to secretion by huffing, blowing the nose, and the caregiver should be seated close to the ear breathing. One hand on the abdominal muscles and other on the upper chest. In treatment, we are slow inhalation through nose using the diaphragm, 2 to 3 second breath hold or collateral ventilation. Exhalation with mouth, vibration of mucus felt with the hand place of the upper chest. High frequency in secretion in smaller airways and low frequency secretion move to the larger airways. In first the unsticky phase, this phase mobilizes the mucosa from periphery to the lung by lowering the mid-tidal volume, and inspiration is followed by the deep expiration into the expiratory reserve volume. Second is the collecting phase. In collect the mucus in the middle airway to the increasing the lung volume. Tidal volume is gradually changed to expiratory reserve volume to inspiratory reserve volume. So lung are expanded more compared to one, and patient increase both inspiration and expiration move greater volume of air. This low to middle lung volume continues until the sound of mucus is secretion. Third is the evacuating phase, in which they increase the inspiration into the inspiratory reserve volume. Middle to high lung volume range until secretion are in the trachea is clear by the stronger expiration at high huff, and duration depend upon the amount and viscosity of the mucus. Each average it up to the 30 to 45 minutes. It also about the very depend on the patient. Advantage and disadvantage. It doesn't require any equipment, can be performed independently over the 12-year of age, not in the PD position, so can be given of any gastroesophageal reflux, not used to the patient who are unmotivated or uncooperative of children. In graph we are shown all the phases, sticky, unsticky and collecting phase. Seventh is high frequency chest wall oscillation, in which compression of the chest wall is frequency of 5 to 20 Hz. Compressive force added using the inflated jacket adjustable to the sangle over the thorax. This is linked to an air pulse generator with the elevated intermittent positive pressure airflow into the jacket. As a result of the jacket rapidly expand, compressing the chest wall, producing the transient shrinking in the airflow in the airways. Mucus clearance is enhanced as a consequence of this airflow or oscillation and vibration of the airway walls. These are the jackets picture shown. 8 is the positive expiratory pressure, in which several devices were used. They deliver the PEP in the either oscillatory or smooth flow method. Positive expiratory pressure include the one-way breathing valve and adjustable level of the expiratory resistance that create the back pressure to stent the airway opening during exhalation. PEP therapy involves the active expiration against the fixed orifice flow resistor or variable office threshold resistor capable of the developing pressure of the 10 to 20 cm H2O. A patient uses the PEP in cycle of about 10 breaths at the tidal volume with slightly active expiration followed by the huffing and coughing. In high pressure PEP, we include the inspiration is performed to the total lung capacity followed by a force expiratory maneuver against the PEP mask which connected to the spirometer. The equipment consists of the ventilator mask, one-way valve and various resistors. Spirometry is used to determine the appropriate resistance for each individual patient. First is 12 mm resistor for infants, 2.5 3 mm older for children and 3.5 mm for adults. These are the picture in SPO, face mask with spirometry. And then flutter. Flutter is a small portable device. It is a pipe shape with a single opening of the mouthpiece and the series of small outlet holes in top of the bowl. The bowl contains the high frequency density and stainless steel bowl enclosed in a closed cone. During the expiration, the movement of the bowl along the surface of the cone creates a PEP and oscillatory vibration of the air within the airways. The device is held horizontally and tipped slightly either the downwards or upward until the maximum oscillatory effect can be felt. The flutter is placed in the mouth and inspiration is either through the nose or through the mouth by breathing around the flutter mouthpiece. A slow breath is only the slider, deeper and the normal, with breath hold for the 3 to 5 seconds and followed by the breath out through the flutter as a slightly faster than the normal. This is known as the mucus loosening and mobilization stage. After 4 to 8 nose, this breath, a deep breath with a hold at the full inspiration, is followed by the forced expiration through the flutter. This may be repeated as a second time and is a mucus elimination stage. It may be participate as a expiration and should be followed by a pause for breathing control following a huff or cough. Is a picture of flutter. They are shown in different pores. Then RC cornet is consist of the curved hot plastic other tube, mouthpiece and a flexible latex free inner tube. The cornet is placed in mouth and inspiration either through the nose or through the mouth. By breathing around the cornet mouthpiece during expiration through the cornet, a PEP and oscillatory vibration of the air with the airway are generated. The flow pressure and frequency of the oscillation can be adjustable by suit the individual. If can be used by any position, it is independent of gradual forces and used in similar way to the flutter. This picture is RC cornet. In a capella is other device. It used to counterweight plug and magnet to create a airflow oscillation. It used the same as a flutter and gravity independent. In a capella, there are different types of depend on the color wise they are divided. First is green color, second is blue color, and then light green, dark blue color. First in they are seen the different upon the liter of per minute expiratory flow. They are divided. First green, in less than more than 50 liter per minute expiratory flow, ideal for the most patient. It used and can be till in small volume through nebulizer, is easy to clean, rinse flushed with warm soapy water and best for the short term hospital use. And second is blue color, in which the less than 50 liter per minute expiratory flow, geriatric patient and pediatric patient may use, is can be into small volume nebulizer, easy to clean, rinse, flush with warm soapy water and best for the short term hospital use. And third is light color, is rarely used, is greater than 10 liter per minute in expiratory flow, ideal for most chronic patient and can be in small volume nebulizer. It easy to clean, discernibles and clean, disinfect, expanding active working life and best for long term patient in hospital for hospital or home use. Last is bubble PEP. In bubble PEP system that incorporates a column of water, to the level of the PEP require 10 to 20 cm per H2O and asking the child to blow through the column of water for flexible straw tubing and adding a little liquid detergent to the water. On exhalation, produce the steam bubbles. It is important that the child is instructed to only exhale through the tubing and never inhale. These are picture of the bubble PEP. They are very easy to do child. Then suctioning. Suctioning is the mechanical aspiration of the pulmonary secretion from a patient with an artificial airway in a place. Suctioning is a negative pressure applied with the airway. It can be done via nose, mouth or via tracheostomy tube. in intubated patient, ICU patient. Indication: patient has the inability of clear secretion, ineffectiveness of efficient cough reflex, or evidence or retained secretion in upper airway. Type of suctioning: first is open suction system and second is closed suction system. Open are regularly used in intubated patient, and second closed, this is used to facilitate the continuation mechanical ventilation and oxygenation during the suctioning. Is mode of entry via the suctioning, different types. The suction catheter may be introduced as a respiratory tract via nose, mouth, or tracheostomy tube. Tracheostomy tube or ET tube. A contraindication in which risk of infection, acute bleeding or trauma, hypoxia, cardiac arrhythmia, atelectasis, acute facial head of neck injury, and bronchospasm. In mode of entry, they are discussing first nose, mouth and tracheostomy, and risk of infection, acute bleeding, hypoxia, atelectasis, cardiac arrhythmia, acute facial head and neck injury, and bronchospasm. References which are used: Physiotherapy and Respiratory and Cardiac Problems, Pryor and Prasad book, and second is Physiotherapy and Respiratory Care, Alexandra Huff. Thank you.